belonging to emergency department, and I'm doing interventional radiology and diagnostic radiology. And today I'd like to talk about CT scan for hemodynamically unstable trauma patients. And all of us know that for extremely unstable patients, there is one option. Surgical approach is the only one option for those patients. And there's no chance for imaging and endovascular procedures. Like the setting on your right, only a surgeon can save this kind of patient. We cannot. We are too slow to save this kind of in this kind of setting. We are too slow. But otherwise, diagnostic imaging and endovascular procedures are very useful, and I think those are essential. But important thing is, it is only when appropriately applied. As you know, major guidelines do not recommend CT and endovascular procedures for unstable patients, maybe because of poor on-time availability of radiologists or the lack of passion of radiologists for trauma. In Japan, this is one of the reasons, and can be because these are thought to be time-consuming process, while lack of understanding the usefulness of time-conscious radiology. So we need to have time-conscious concept in radiology in trauma. That's why we have suggested PRESTO concept in 2015. And PRESTO is the abbreviation for prompt and rapid endovascular stretches in trauma occasions, and consisting of 4 factors. The first is early activation of our interventional and diagnostic radiology team. Here you can see me and other radiology personnel waiting for the patient together with the clinical team. And in this picture, you can see me waiting for the patient to come next to the monitor. That this monitor is located at the head area of the patient. And once we get the patient, and when we get the portable chest and pelvic X-ray, I stand in front of the monitor, and I will give them the comment about imaging, like left-sided rib fractures and no hemopneumothorax noted, but the left-sided impact can suggest possibility of splenic injury. So how about fast kind of discussion we can start from the beginning. And it is also very, very important. If you want to scan hemodynamically unstable patient, you have to have ultra-fast scanning protocol and quick evaluation method of CT images. Here, this is the movie from training for ultra-fast scanning protocol. We do this every month, once a month we do this. And to do this with using 80 kilogram phantom doll, and to do ultra fast scanning, we do not obtain scanning scout image. We already started the CT machine before the patient coming, and we set the patient in a certain position. Then we start actual scanning with giving contrast, and finish head CT before the contrast comes to the head. We start to scan with giving contrast, but we finish head CT before the contrast comes to the head. And after that, 20 to 25 seconds, we start arterial phase, the real arterial phase for whole body. And after 60 seconds of the arterial phase, then we start second phase, the portovenous phase, after 60 seconds of arterial phase. Then in this case, we could finish the whole process, like after CT scan, we take off the patient off the scanner, and we are going to take the patient out of the CT room. And in this training, if you look at the time, it says 2 minutes and 52. So you can finish non-contrast head with giving contrast, and whole body arterial and portvenous phase you can finish in 3 minutes. So if you can do this, I think you can scan more hemodynamically unstable patients. And this is the actual image from the actual case. And in this patient, we obtain a planning scout view, so it takes longer. But we got the patient and the start scan for the non-contrast. This is a planning scout image, and after that, we do a non-contrast head CT with giving contrast. Before it comes to the head, we finish the head CT, then arterial phase and delayed phase. So even in this actual patient, we could finish the whole process in like 4 minutes and 55 seconds. So if you train the whole team, you can do this kind of quick CT protocol you can achieve. So to shorten CT room stay time is like pit work. So you need to train the whole team, and then you can scan more hemodynamically unstable patient. And if you can shorten the CT room stay time, you can scan the patient with rebore, with full inflation, or with partial inflation. You can do those patients if you can shorten the CT room stay time. And it is also very important to have a quick evaluation method of CT images, because whole body CT scan provide many CT images, so you need to have quick evaluation method. And we have suggested, and it is now in the Japanese trauma guideline, the method is called focused assessment with CT for trauma, the FACT. And in that, all you have to do is just to evaluate pre-selected areas and pre-selected pathologies. And starting with the head to look for surgical or intracranial hematoma, and like this, not minor fracture or minor subarachnoid hemorrhage, you do not evaluate, just find surgical lesions and go down to the aortic arch level to look for the aortic injury, and then go down through the lung to look for bad lung injury and hemopneumothorax. And below the diaphragm, you have many organs. So, but the most critical pathology is the large amount of hematoma. So we go down to the pelvic floor. Because large amount of hematoma goes down to the pelvic floor, where it is the most dependent area. So that's why we go down to the pelvic floor first to look for the significant amount of hemiperitoneum. And retrogradely, we go up with looking at pelvic and spinal fractures with retroperitoneal hematoma, which is not evaluated during primary survey. And after that, we evaluate solid organ injuries and mesenteric hematoma. Important thing is you have to finish the whole process within 3 minutes, ideally during the CT examination before the patient goes out of the CT room. And it is also important to not to stop even when in doubt. And it is also important that you have to start a second step of imaging evaluation immediately after focused assessment. And you have to, in this step, you have to integrate all clinically available information with imaging findings. And we call these factors THINK. Time is time from the event, and hemodynamics, imaging findings, and number and location of injuries, and the kinetics of trauma, the mechanism of injury. if you can combine those informations, you can develop better strategies with imaging findings. So it is important to think of a mechanism, because you do not have to search injury. You can predict what is going to happen. So all you have to do is you can look at expected injuries. So it is important to think of mechanism for efficient reading method. And it is very, 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 very important to assign someone for imaging evaluator during the examination, or even immediate after examination. And during the secondary survey, I sit next to the monitor, behind the monitor, and if I find something, I scream to the people, extravasation from the spleen and pelvis, but hepatic injury do not show extravasation. Those kind of information will be shared immediately after the evaluation. And it is also important to transfer the patient directly from CT to angio room or operation room. And in this case, we could start surgical procedure, neurosurgical procedure, and angiography at the same time in the resuscitation unit immediately after CT, according to the findings of FACT. And if we take the patient directly from CT to OR, I go with the patient and keep on reading the images, and I will give more information to surgeons during operation. And it is also very important to apply damage control concept in this PRESTO concept, but I do not talk about this today. So as compared to the conventional protocol, if you apply PRESTO concept, and if you can shorten the CT room stay time, and if you apply the quick evaluation method, you can save time. It means you can save life. So for hemodynamically unstable patients, because of the instability, I think you need to scan the patient. But if you want to scan the patient, you need to have a right concept. So for better or best strategy, need CT information, and because of the instability. But if you want to scan the patient, multidisciplinary trauma radiology team with time-conscious concept, and you have to have method, but still you need to select the right patient. For further solution, in Japan recently, about 20 institutes have already installed this kind of hybrid emergency room system, HERS. In this institute, they have all-in-one trauma resuscitation unit. Here they have CT and angio, everything in one place. So they do not have to transfer the patient to the other places. They can do angio and the surgery in one place. And now it's getting more popular in Japan is two-room system, dual room type hybrid EL. There's a CT room here, but the resuscitation unit is here. And only when they need CT scan, the scanner is coming into the room. And after scan, they go back to the CT room. So you can use both rooms. So this is getting frequently, and we will have this system in 2 years. So this is the movie from the actual case in the dual phase, dual room system, and young male patient with motorcycle accident transferred from another hospital, and very unstable patient. And in this institute, so often, many times, they scan immediately after the transfer. I mean, once they get the patient, they immediately scan the patient. But in this patient, they do resuscitation procedure first. So then they gotta have to start the scan 15 minutes, but most of the time they scan immediately after they get the patient. And in this case, you see very, very bad liver injury with massive extravasation. And they like this, and they start damage control surgery. in the same room without transfer. So they can start surgery very quickly. And after surgery, in a bring room maneuver, they found sustained active bleeding. So they start angio in the same room without transfer, and they embolize the artery, and they could stabilize the patient in the same room without any transfer. So they can do the whole thing in a shorter time. Thank you for your attention. Now I'd like to say, scan them all and save. So what do you say, Dr. Tan? Thank you for your attention.
Thank you very much, June, for your very nice and for some aspects, really, really, really great presentation. Let's see what Professor Tan will give us from his experience in Netherlands.
Yes, well, thank you to share my thoughts about this topic. First of all, I would like to congratulate Jun with this excellent presentation. I'm very impressed that he has all that hybrid CT even in the ER. The future is coming. And of course, I would like to have that also in my ER. But of course, not in the whole world, we all have CTs in our CT room. So what I'm going to do is I'm going to discuss the following. I'm going to talk about the transient responders in trauma. Are we going to scan them or not? Because that's a hot topic actually in my country. And first of all, we have to realize that we see approximately 6 million people who are injured due to trauma. And that's resulting in 10% of the world's death. And you have to realize that injury affects all age groups. There's not only the adult patients, but also the young ones and also the older patients. So there are some side effects of using a CT scan. Of course, we have been taught by the ATLS principles, which goes A, B, C, D. And as stated in the well-known ATLS manual, they say, well, the imaging is actually an adjunct. In trauma, we have to work with mechanism of injury and we have to work with probability of injury. So we always have to think, what is the reason we need some additional X-ray examination or we will need CT scanning? Again, the treatment of a bleeding is to stop the bleeding, not by diagnosing the bleeding. So as also stated in the ATLS manual, use imaging judiciously and do not delay patient resuscitation. So if you look further in the ATLS guidelines, you will see that the transient responder, well, it's transient. There's a transient improvement. But those patients may have blood loss to adding up to 40%. And you can see, again, the need for an operative intervention is very likely. So key issue in this one, of course, stable patient and who has had a polytrauma or is involved in an accident, a polytraumatized patient with a lot of injuries. Based on the mechanism of injury, well, we scan them. That's no discussion. And of course, the non-responder or the patient who is hemodynamic unstable, he will go directly to the OR. But what about the transient patient? And then the key issue in this one is what's transient? I discussed it with a lot of my trauma colleagues here. And for one, a transient responder may be just one fluid bolus. And when his pulse is going down and his blood pressure rises, it's a transient responder. But then the word comes in transient. How long is transient? Is it 5 minutes? Is it 5 seconds? And is it a transient responder also a patient when there's an anesthesiologist squeezing 2 IV bags with blood in this patient or getting inotropes necessary? Is that also a transient patient? Because what we do not want to have is a patient who is crashing in your CT, because then you will have the donuts of that. So it's all about decision making. And as June already mentioned, you will do it as a team. And in our ER, we will have on a trauma call, we have a surgeon, we have an ER physician, we have an anesthesiologist. And what's very important that you already mentioned, and we saw it in your beautiful videos and photos, there will also be a radiologist who's dedicated to trauma. because sometimes in the past we had radiologists who doing a spine or imaging of the brain, and who are not so good in trauma. So you'll need a dedicated team, a multidisciplinary team, to discuss what are we going to do with the patient and where are we going to go with that patient. And if that patient, of course, is hemodynamically unstable, well, we go directly to the OR. But the big one is the transient responder. When is the patient transient? And of course, as you can see it in this picture, we have the luck that we can make conventional X-ray in our room during the resuscitation. Just as a normal X-ray, chest X-ray, and a pelvis X-ray, you can do it in our room. And of course, don't forget the sonography for trauma. You have the extended FAST, the focus assessment sonography for trauma. You can have it with a standard sonography apparatus, but up to now, you even have a probe. You can just plug it in your iPhone, and you can make a simple, quick eFAST, which is very sensitive in detecting free fluid. So if you have an unstable patient or a transient responder patient who has had a big injury or major injury, you just can detect if he has free fluid, and then, of course, you don't need a CT to diagnose it. You go directly to the OR, because the treatment of the bleeding is to stop the bleeding. And again, other things you may diagnose it, because a lot of ER physicians and emergency surgeons are can make an eFAST by themselves. And well, detecting free fluid is easy. 90% can do it, and even more. But also a tamponade or a pneumothorax, you can diagnose as simple with an eFAST. So, and when are we going to CT? Well, if it's a transient responder, and the anesthesiologist will say if everything is under control, if there's a tube in and even chest tubes in, and well, if you don't have such a nice thing as a hybrid ER, you will have to transport the patient from your resuscitation trolley to the CT room. And during that period of time, of course, things can happen. So you will need a qualified transport. Well, in the ideal world, and June already mentioned, and we saw the videos about it, the ideal world is, of course, that you will have a sliding gantry. So you get that patient from the ambulance stretcher to the sliding gantry CT stretcher. You can resuscitate the patient, and if he is transient or stable enough, of course, it's easy. You go to the CT and you can do it in a couple of minutes. And even you already mentioned, if you have a hybrid ER, it's even more better. You have CT, angio, and you can even do surgery there. But again, you don't want to have that patient crashing. If you decide, based on the probabilities of injuries, to do some imaging, you can decide to do conventional or a CT. But you will have to have a CT even in your hospital. And of course, not only do you have to have a CT, but you also need some radiology techs, and you will need a dedicated radiologist to look at all the imaging. And of course, what's even better, you do a first reading, but also a second reading, and even sometimes a third reading, because sometimes diagnosis can be missed. And what we do not want to happen is that that transient responder will become a non-responder. Concerning evidence, in the Netherlands, we had a big study, the REACT study, and one of the major conclusions, which was published in the Lancet and by Seering and by Long in the American Journal of Emergency Medicine, there is no mortality benefit to this diagnostic tool in CT scanning. Time, well, you saw nobody is timing how long it will take to do the CT. Well, we have timed it in our hospital. As you can see, we have our resuscitation room here, and you can see there, well, I hope you can see it here. You have the CT room. That's, well, approximately 10 feet away, but it will take 18 minutes in our hospital to get that patient there. From the resuscitation trolley to the CT and to scan the whole patient. And of course, if you decide that you want a CT, you should consider that you want the best imaging quality. So mostly we do a non-contrast head and neck CT, and after that we do a split bolus contrast, but we put the arms in the air to have better imaging quality. But again, that will take time. Now, radiation, the difference between a whole body CT, that's approximately 10 millisievert, And a conventional chest X-ray is 0.04 millisievert. That's a factor of 250 concerning radiation. So you should consider that. And why, of course, is radiation an issue? Because we do know that if we scan young people at a certain age, the chance, the lifetime risk in getting cancer is increased by 0.05 to 0.01%. So you should always consider that if you do one CT and mostly after 24 or 48 hours you do another one CT, they all add up and they will all increase the risk of getting cancer. Again, if you decide to do a CT based on the injury mechanism, you use contrast, but there are some disadvantages concerning contrast, of course. We use the split bolus contrast because our patient category may have an impaired kidney function. In the Netherlands, more than 20% of the patients who are arriving at our ER are above 70. And a lot of those patients will have some kind of kidney failure or of diminished kidney function. So if you make a CT and you use contrast, there's always a possibility of contrast-induced nephropathy. And as we have the older patients, we also have the younger ones and the children. And as stated before, you don't want to scan little children or girls in their teenage years because of the higher risk of getting cancer. The lifetime risk of cancer in getting radiation is, of course, increased. So you can just use conventional radiology. And we call it the donut of death when the patient is crashing. On the other hand, June will say it's a tunnel of truth, but we can see everything. But again, there's literature, you cannot see everything on a CT. You will miss sometimes things. And this is just a figure, but it's approximately between 2 to 4% that diagnosis will be missed. So that's important that CT is not everything. You cannot see everything. So in summary, in the treatment of our polytraumatized patient, just follow your ABCD. If it's an unstable patient, go to the ER because the treatment of a bleeding is to stop the bleeding. And mostly that's not the CT, but you have to do that as a surgeon. Stable patient, well, no offense, but we can scan them and see radiology as a tool, not a treatment. Thank you.
Edward, thank you very much also for your presentation. This is right the opposite, because Edward is also, no, it's mainly a surgeon and then a director of the emergency department. So his speech is a surgeon's speech.
Yes, of course.
Any radiologist can tell you that even interventional radiology is a tool and not to try to stop the bleed and to save lives. But you also know, because you mentioned every time. Maybe before answering to the first question came from Dr. La Greca, you can see there in question and answer section, I will read for everybody, but maybe one of the first thing that we have to take from these two opposite speeches is that the main point, if you decide and if you want to scan the patient, even in a condition that is not a perfect normally hemodynamics, is a teamwork, because everything needs a lot of preparedness and a lot of drills in order to improve the times and the maneuver, to reduce the unnecessary things that will take will take to lose a lot of time during the patient management. This is the main point that we should focus on before discussing about, because in Italy, but many other parts of the world, we are moving toward a more improved organized system in order to try to reduce the time and the wasting of time in our center, in many other trauma centers, but as well in other parts of the world, because many people are trying to promote a drill system in order to improve the time. As Juniki told us, they have a drill each month, at least one drill per month. And I think that not so many hospitals in the world has one drill per month in order to improve the time to the CT or to the OR. Dr. La Greca asked us, what about portal phase only to select those patients that really need a whole amount of contrast media and the whole scanning cycle to rule out a suspicion of arterial blush and the indication for embolization? Please, guys.
Let me answer the question. We are thinking about how to treat the patient. So to judge how to treat or how to approach the patient, for example, endovascularity, we need information about arterial anatomy and that imprecise. So in that setting, we need information on arterial phase. That's why we scan two times. But if the patient don't, if you don't think the patient is bleeding, in that setting, only portal phase is enough. But now you're thinking hemodynamically unstable patient, you're thinking the patient is bleeding. In that setting, I think it's better to have two phases, arterial and portovenous phases, I think.
Yeah, I concur. We have, I just skipped it a little bit, but we have a split bolus protocol in which you can see arterial phase and also the early venous phase.
Yeah. That is that you can reduce the radiation dose so that for younger patient, if it is not, the patient is not so unstable, and we do split bolus scanning. So the scanning is just once, but we add contrast material to the artery. So we scan just once, but the contrast material is in the organs and artery. So when you scan the portal phase, if you add contrast during a CT scan, so you can have vivid arterial images, and also you have contrast enhanced organs. So one solution to reduce radiation dose is split bolus technique is one of the solutions. But I prefer, if you have very badly bleeding patient, I prefer to have both phases with bolus injection. Yes.
There is a comment from the Ireland, Professor Balfe. He wrote us that when both thorax and abdo are involved in trauma, the 25% of the times the trauma surgeon starts in the lower priority cavity. So rapid CT would eliminate this mistake, but need a suite like in Professor Jun's unit.
Yeah, that's a good one. If I had the same equipment and a dedicated radiologist, it's an ideal world. In 3 minutes, do a PAN CT would be great. It's a kind of blue sky scenario for us. But I agree with that statement that sometimes the surgeon may call to open up the wrong cavity. And the CT would, of course, in that transient responder or even the semi-unstable patient would be of benefit, maybe of benefit.
June,
I agree with that. So that's why we scan them all. But the important thing is, if you want to scan them all. So, but we do not scan them all. But if you want to scan many patients, you have to have right method and right team with right concept. Without those, it is not good to scan the patient. It will take time and evaluation time longer, so you will waste time before surgery. So without having that concept, I think you cannot scan the patient. So you have to have right team with the right concept.
Yeah, and that's the most important message, actually, which you would spread across the world. It's a team effort. You will need dedicated patient, and you should discuss it. Why do we need the CT? And is our probability of injuries? Do we need a CT for it? Because In that same case, if the chest and the abdomen are injured, you have to get the priorities right. And CT can be useful, but can also be delaying the right choice. And that is important that you will discuss it with your team, with your radiologist, and that radiologist should also be part of the trauma team. And that's not in all countries.
Actually, sometimes, not many times, very rarely, but that can happen. I mean, I stop them to scan the patient. No, 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 this patient is not for scan. What are you doing? You stop, open the abdomen right now, right here, kind of comment. Sometimes I need to say the team, because they are now like CT scan. So younger surgeons cannot move without information from CT, but it is not good. Important thing is establish surgery-oriented base first, then at the same time, or then you can create as further system like aggressive radiology system or something like that. You can put on the base, but you have to create solid surgical team first. Then after that, you can add radiology or some more thing. But the important thing is, most severe patient, you need to save your hands. So that's why you need to help the surgeons to do right thing without scanning. So sometimes we stop them to scan.
Yeah, and that's a good thing that well, it's good to hear that you say don't scan them all. And sometimes there's also a reason not to scan them. Again, it's decision making. It's surgical or anesthesiology or radiology decision making. And again, good judgment comes from experience, but we all know experience comes from bad judgment. So it's very important. Again, it's a team decision, and that could be stressed. I couldn't be stressing this more and more.
Another thing that should be stressed, in my opinion, is that in John's situation, he has maybe one of the highest level of facility from the radiologist point of view and from the team point of view. But in the most part of the world, even in some other parts, these facilities doesn't exist. So for example, in our hospital, we are hub trauma center. We have no this kind of facility in order to have this very fast time for scan. So we have really to decide who would need to be scanned or not. For sure, Professor Balf told us something that is really true. Sometimes you start from one in 4 patients, you will start from the not priority cavity for bleeding point of view. But we should consider that in the remnant patients, the prevent to perform a CT scan will improve the possibility for them to survive, because if you have not the facility in order to have 4 minutes CT scan, complete CT scan, you should have to think really about performing CT scan in transient responder patients, because you will take at least 30, 40 minutes, because sometimes the people who answer to our questions told us that in 15 minutes, people in their hospital are completely CT scanned. In my opinion, it's really, really short amount of time, because in the reality, 15 minutes to have a complete CT scan in a polytraumatized patients is something that is futuristic. Maybe yes, in Juniki hospital, but in the other hospital, at least 30, 28 to 35, 40 minutes to complete the whole procedure in shock room, and then in CT scan, and then back, and then to the operating room. So I think that a word of caution must be raised, because many people from many parts of the world, even many residents, are listening us. So as you both told, not all patients should be scanned, even if the something could be thought about it, because you may improve the diagnostic power, you may know something like minor lesions, you have to save the life of the patient. So CT scan is something that should be used with caution, because it's useful, but is even maybe very dangerous. So this is a word of caution because many residents are listening us and they have to learn the fundamental concepts. We have many other questions. Professor Bala from Israel. Do you think that CT should be done in non-trauma center and transfer to level 1, or just transfer after initial stabilization without CT scan? And then Professor Navzaria from South Africa asked us, do you scan patients with penetrating abdominal trauma who are transient responders? Guys, this is...
Yeah, concerning the first question of Miklos, one step before that, in our opinion, you should transport a polytraumatized patient directly to a level 1 trauma center, because we do know that the quality of care and the outcome is better. And if that patient is presented in a level 2 or level 3 hospital, again, resuscitate the patient. And if you see it's a polytraumatized patient which will need transfer to a level 1 trauma center, don't delay the transfer because they have different scanning protocols. And although we're living in Europe, even in the Netherlands, sometimes they make a CT scan and they forget to give the CT disc with the patient, because it's still very difficult in the Netherlands to transfer imaging through the internet, because always everything has to be secure and safe. So I suggest to directly go and make appointments with your ambulance service, that if you think that it's a polytraumatized patient, directly go to a level 1 trauma center.
I agree. I totally agree with you. And or if you have ambulance with CT, then the story is different. But you know, so far we don't have. So.
And considering the second question from Pradeep, patient with penetrating abdominal injuries, well, if he has a stab wound to the abdomen and his abdomen is sore and he's hemodynamic transient or unstable, I don't need a CT to know that I have to go to the OR. So, and I do know that I have colleagues, they want to have an CT because then they know and they can prepare. But if you train your residents if you train them according to damage control principles, they can just do a damage control laparotomy and just fix the problem. You don't need a CT for that, in my opinion.
In the penetrating trauma, yes, I agree with you. And but fortunately, in Japan, we are living in very safe country, so we do not have many penetrating trauma patients. So we have less experience in penetrating trauma cases, but you know, the penetrating trauma case, it is obvious how to treat the patient. So most of the case, or almost all cases, especially hemodynamically unstable patients, you do not waste time to scan the patient. I think go to the OR is the message, I think.
Yes, because we have not to forget that the primary survey with the fast extended ultrasound, we have a lot of information with the basic, the first level radiology. So that is something that really give us a precise idea on where usually go to operate and how to manage the patient. So this is something that we also hear in almost all part of the world. In penetrating and a stable patient, no CT scan is done and should not be done because it's really dangerous.
May I ask a question to our panelists? But I agree totally with there is no, by the fact that there is no indication usually for a penetrating trauma to scan the patient who has been a transient responder 1. However, what about that kind of penetrating injury? For example, firearm bullets or gunshot bullets that are penetrating or are exiting from the body in questionable areas. In the part where you cannot be sure that, for example, the thoracic cavity has been entered or not. And I think that in in a very little part of cases, if a patient we have some doubts about the track of the ballet and the patient has been stabilized, although it's a transient one, if we have time, it could be worthwhile to perform a scan or not.
Well, again, it depends what are the vital functions. Of course, I agree that if you have a penetrating gunshot wound to the abdomen or even to the chest, and you don't see an exit wound, then you would like to know where the bullet is, because again, you are talking about probabilities of injuries. You will see and you can mark with the bullet marker the entrance wound, and then you can see somewhere, if you do a scalenogram, the bullet, then you know what is injured, and a CT may help you. But again, it depends what are the vital function of that patient. Is he stable enough to go to the CT?
Dr. Liberti, is a colleague from neurosurgery, raised a question that really it's important, because we didn't discuss this, but it's important. He asked us, what do the colleagues do when a patient with polytrauma has a contemporary bleeding in the head and in peritoneum, both life-threatening? This is hard.
That's a good one. Again, C comes before D. So what we do if we have an unstable patient and has free fluid in his abdomen, but he is also involved with a severe head injury with a blown pupil, you have to discuss, are you going to the CT or to the OR? And again, this depends, and it's a team decision what you are going to do. And if that patient is a non-responder or a very temporary transient responder, you go to the CT, to the OR, because the treatment of the bleeding is to stop the bleeding. And after you have packed that patient, you can go to the CT and do a CT head. And if that patient is really very bad and you have a real blown pupil, which was not blown, for instance, 10 minutes ago, then the neurosurgery may consider to do a burhole or something like that, or even do a craniotomy blindly on the other side. But again, this is a team decision and you will need your team to discuss it. But priorities are clear. The C is before the D.
I agree. One of the possibility in many centers where facility of June are not present, maybe the sort of, if you really suspect an important lesion in the head with an unstable patient that is not suitable for the CT scan and suitable for the operating room, if you have a good teamwork, you can perform an ongoing CT scan in which you perform only the head CT, and then you may know what is happening on the upper floor, and then you can operate on the lower one, and then maybe you can fix both the problems. The operating room allows you for doing both procedures together, but it's something that should be really prepared and organized, because the patient in this situation are really rare, fortunately. But just for resident who is listening us, it's important that C is before D. So the bleeding is something that is taking the patient to the death before the head. Even if the lesion in the head is important and it's a high-grade lesion.
Yeah. Unless you have the possibilities of June to have a hybrid ER room in which you can do CT and operate and do everything in 1 minute.
Yeah. But even
Yes.
another point. Sorry, June. Please.
No, we need to, we should not solve the problem with facility. I mean, the level of the facility is not the answer. You need to create the right team suitable for your setting. So, don't think about getting the hybrid suit, but before that, you need to consider what you can do in your setting. What is the best solution in your setting is the important. don't think about the hybrid. Don't think to get hybrid. So that's not the solution. So that's important message from me.
Yes. So, guys, we answered to all the questions, and I think that we went in deep in many different point of the issue, and even you both gave a lot of important messages to all the guys who are listening, and especially to all the residents who are learning a lot from these meetings. So we really thank you both for your participation. Massimo, would you like?
Yes, it has been a very interesting webinar. Obviously, the message that is coming out from the presentation is to have a teamwork dedicated to the process, to be as quick as possible to perform diagnosis and even treatment, maybe to have the opportunity to scan quickly all the patients with trauma, may ensure a lower rate of surgery and more implementation of interventional radiology. But anyway, the message is to be fast and stop the bleeding. Stop the bleed would mean to open the abdomen or the thoracic cavity if you have no other opportunity, or try to implement innovation technology to stop the bleed. But the message, you have to stop the bleed as quick as you can.
Okay. So thank you very much to everybody for participating. It's almost 4 o'clock, so we have to close. We have to say good night to Juniki and and good evening to all the other people. Thank you very much for participating and for being with us.
Goodbye, everybody.
See Bye.
Thank
you
all.
very much.
Ciao.
Ciao.
Thank you. Thank you very much.
Thank you, June.
Thank you.
Ciao.